Dr. Escott has a very long and prolific career in EMS and emergency medicine, but I just wanted to introduce him because he's the reason I got into emergency medicine. And if you guys don't know me, my name is Farouk. I'm the chair for the medical student committee. I'm also out of breath right now. But before I was any of that, I was an EMT at Rice EMS, which Dr. Escott founded back in 1996. And if you guys don't know what that is, it's a collegiate EMS service that teaches you how to become a leader in everything that you do. So my resume for med school had one bullet point, Rice EMS, and people would talk to me about it. And they're like, well, did you do any leadership? Yes, this organization. Did you do any community service? This organization. Did you do any administrative or academic stuff? This organization. So without further ado, a man who has allowed me to be in his presence for several years and learn from him, exceptional mentor to dozens and dozens of kids throughout the years, and hundreds of medics, thousands of paramedics, Dr. Escott for EMS.
Do I have a slide clicker or this? I know how to press the buttons. Thank you for having me. Thank you, Farouk, for seducing me to come down here. I did set new land speed records. It's nice when you travel at 7 o'clock in the morning on a Saturday. There's nobody on the road, so luckily there weren't police on the road either. That's why it's nice to have a badge sometimes so you can maybe talk your way out. So I'm going to talk today about the newest subspecialty in emergency medicine. And it's the most exciting because, you get flashy lights and badges and so forth, and you get to be paid as a doctor, and it's wonderful. I was a paramedic for many years, for 9 years before I went to medical school, and that's sort of how I got into this business. Unfortunately, it's like having a lifelong virus. You can't shake it, and it's nice to have the opportunity to do this as a physician now, and that it's finally been recognized as a subspecialty. So I'm going to talk a bit today about the subspecialty that is EMS now, how this transitions what a paramedic is. I'm going to talk a bit about how we have to set different expectations for our paramedics and create practitioners out of them where they've traditionally been technicians. So back in 1973, the National Highway Transportation Safety Act there's the Act of 73 and the Act of 66. Both of these acts established EMS in the United States. And back then, they were basically ambulance drivers, right? Anybody see the picture of Queen Elizabeth this week? The most famous ambulance driver of all time. So what's happened since then is that we've had a bit of development in the field of EMS and emergency medicine, and so that role has transitioned over time from what used to be, a hearse, right? So the funeral homes would go out, there would be a car accident, you'd pull up on the accident. If they were dead, they'd go to the funeral home. If they were alive, you'd stick them in the back of the hearse and drive them to the hospital, right? Because you had a stretcher that could fit a human being on it, and there was no care that happened along the way. It was just a transport service. In fact, in many parts of the world, that's the way it still is. I had the opportunity last year to travel to West Africa during the Ebola outbreak and see the ambulance services in West Africa. And this is basically what they do. Load them in, drive them to the hospital, drop them off. So it started as an emergency service similar to police and fire, where we built, we had technical needs, we taught them skills, but over time it's transitioned, like I said, from drivers to people who actually had skills. So what's happened since 1977 is there's been a huge amount of research done in the pre-hospital setting. There's been stroke studies, STEMI studies, lots of research in resuscitation. In fact, the significant majority of cardiac arrest resuscitation research happens in the pre-hospital environment, okay, because it turns out that's where people die, right? Something like 63, 65% of people who have cardiac arrest experience that in their home. So after a long, tortuous path, in 2011, the American Board of Medical Specialties decided that EMS should, in fact, be a subspecialty. And it's not just a subspecialty because it requires administrative oversight of a physician. There's a distinct body of knowledge that is similar along the lines to emergency medicine, right? They made the same argument against emergency medicine when it was created that, well, you're just a triage officer and you don't do anything else. That's not true. It turns out that phase of care, what you do in that first period of time, is very, very important. All right? So now we've moved that time period forward by 30 minutes or an hour in the same manner with EMS. Sorry, this stage is rocking a little bit. So how does that change things? All right? So in many specialties and subspecialties, we have physician extenders, right? Well, by creating EMS as a subspecialty, it automatically, in my mind at least, transitions paramedics from technicians to physician extenders, right? They're not doctors, and they work under our license, all right? You have to understand that the way paramedics operate under the direction of a physician is different from state to state. And in a lot of states, medical directors have supervisory responsibility only, okay? So the paramedics aren't working directly under their license. They're technically working under the license of the state of whatever, or the Commonwealth of whatever, with the physician providing input. In the state of Texas, paramedics work directly under the license of the medical director, or the EMS physician. Okay, so it is direct oversight and responsibility in that circumstance. Okay? The problem is that we can call paramedics physician extenders, but we have to appreciate the differences, the vast differences between what a paramedic is and what something like a PA is. Okay? Paramedics, generally speaking, have a high school diploma and a certificate. All right? If you're really educated as a paramedic, you have an associate's degree. Okay? If you're really like in the top 5% of paramedics, you have a bachelor's degree. And it's almost unheard of to have a graduate degree. Okay? What's it like for PAs? Lots more education, right? Bachelor's degree, master's level training as well. Well, what about the work environment? Well, we've got paramedics who, generally speaking, you have a paramedic and you have an EMT, and they're off in the middle of nowhere by themselves. You may have some firefighters to assist, some police officers to assist, but they work relatively autonomously without direct oversight of the physician. And they're seeing the most critical patients in the most difficult circumstances with limited equipment and limited backup. Whereas our PAs, generally speaking, PAs working in emergency medicine are seeing what kind of patients? The low acuity patients, right? They're seeing fast track patients, the sore throats, and those sorts of things. It's different from place to place. I've worked in places where the PAs are seeing sick people also, but generally speaking, they're seeing lower acuity patients. All right, and they have direct oversight of physicians who's working in the ER with them. If they have an issue, they have a question, they're not sure what's going on, they call the doctor and say, hey, can you take a look at this patient? Can I talk to you about this patient? That sort of thing. All right, we obviously have differences in salary. Average medic in the United States is making somewhere in the range of $40,000 as opposed to $100,000 or so for PAs and other physician extenders. So how do we fill in the gap, right? How do we fill in this gap between the technicians we've had and the clinicians that we want to create? And part of that is we have to transition the quality measures of EMS providers. All right, this is where the physicians come in. And you got to understand that this is a struggle. All right, this is a struggle for me, who's one of a small number of people in the United States who are subspecialty board certified in EMS, because traditionally EMS has been run by fire departments and EMS paramedics who've risen through the ranks to be in charge. So what they know is this kind of quality. Okay? Sorry. I'm looking at the slide here and it looks like it's up on, but it's not. All right. They want to talk about, did the paramedic clean the ambulance? Did they clean the station properly? Are they wearing their uniform? Do they have an extra pin on their badge that they're not supposed to have? That's all crap, right? I mean, that's not stuff that clinicians need to worry about, right? God forbid if I was responsible for stocking the ER, all right? Stuff would not be stocked, okay? Stuff wouldn't be where it's supposed to be, because that's not how I think. I'm hired like we hire our paramedics to be clinicians, to critically think, to think outside the box, not to wash the trucks. Doesn't make sense, all right? Things like shoot times and turnaround times. So this is how fast they get out of the station, how fast they turn around at the hospital. These are ridiculous measures for clinicians. All right? And the gold standard, of course, is what's the response times for our medics, right? Because that's the most valuable single piece of information that we can possibly have. All right? If you go to a budget meeting, a fire department meeting, a city council meeting that talks about EMS, this is what everybody wants to know about. All right? What does the evidence say about response times, though? They don't mean anything, right? For cardiac arrest, it's pretty important. For anaphylaxis, for major trauma, it's pretty important. All right, and that represents, 5% of what we do. The rest of the time, it doesn't make any difference. But we still focus on that, all right? So what about clinical quality measures? Well, clinical quality measures have traditionally focused on really important things like what your percentage of IV success rates are, what your percentage of endotracheal intubation success is, how much you do CPR, your CPR fraction. So out of a minute, how many seconds in the minute are you're complying with the CPR standards, the appropriate depth, appropriate rate, that sort of thing. What percentage of the time your hands are on the chest. I'm not saying these things aren't important, but for clinicians, we have to move beyond the technical skill part and measure the thinking part, okay, which is traditionally left off. Why is it left off? Because we've used this sort of Jedi mind trick with our paramedics and with the public saying, well, paramedics can't really diagnose things, all right? We teach them what to do. They have a protocol, a guideline that they follow, but they're not really diagnosing things. So if they see a squiggly line, they recognize it as VFib. They're not diagnosing VFib, but they're reacting to what they see. It's stupid, right? They're diagnosing VFib, they shock VFib, they start lines, they give amiodarone and other drugs to prevent recurrence. It's stupid to say that they don't diagnose, all right? And we've taught them this don't think model, all right? They got to stay within the lines. If they have a protocol to follow, then the measure of quality of the technicians is to match the protocol with the chart. If they don't match up, they get in trouble. Okay, if they do match up, it's great. Okay? So we're still left with this issue of how we get to where we need to be in EMS as far as medical direction is concerned, and reinventing both the role of the medical director as well as what the clinicians do as they transition from technician. So how did I get there? I took Qantas to Australia where I studied medicine. It turns out, they have an EMS system which is about 15 years more advanced than ours is. All right, UK is the same way. In the Australian system, they require a bachelor's degree to start. That's the entry point. Okay? Across the board, you have to have a bachelor's degree to be a paramedic. All right? This took about 20 years to evolve. It was based on the model that the RNs did in the United States. All right? But they used it to argue for better care and better salaries, and I'll get to that in a second. All right, so you start with a paramedic. Once you become, with a bachelor's degree, once they become a paramedic, then they can enter into the EMS system where they get a provisional offer to be a paramedic. They have 16 months of additional training to be a fully qualified paramedic. All right, that's 6 years of training, which sounds a lot like what we do for our physician extenders in the United States, right? Yes. And then they can go do other things like intensive care paramedic, extended care paramedic, etc. The result is the salaries change significantly in Australia. All right, rather than $40,000 as you're making in the United States as a paramedic, it's 105 or so in South Australia, Victoria, Sydney, and those sorts of places. So we also have to make the transition not only in education, but we have to break people out of this prison of being locked into protocols. Okay, so let me just give you an idea of what that looks like. So this is a real case that I reviewed. This is a 60-year-old female, which is lightheaded. The heart rate was 48. All right, so we teach paramedics to identify patterns, right? We teach them heuristic types of thinking so they can identify patterns and follow them. All right, this is what we do with the protocol. So they identify the protocol. I know what this is. This is symptomatic bradycardia. All right, bradycardia, lightheaded, equals symptomatic bradycardia. So what did the paramedic do for that? Atropine would have been nice. Well, it would have been less impactful than what they did. What's the other option? Pacing. All right, so they put this lady with a heart rate of 48 and lightheaded on a pacer. Okay? So if you're doing quality review in the traditional manner, and this one went to the traditional manner, this matches up. Okay? Patient, bradycardia, check. Symptomatic, check. Paced, check. It all checks out, right? This passed through our QA system without problem. Okay, this is the rest of the story. The rest of the story is her blood pressure was 240 over 150. Okay? So this is a hypertensive urgency issue, not a freaking bradycardia issue. All right, so the treatment should have been managing the blood pressure, not managing the heart rate. All right, and this sort of flawed thinking happens over and over and over again in EMS systems, particularly those that have little physician oversight. Okay, where you're matching up the protocol with the chart. Okay, so what physicians' roles are, and what I see my role as, is teaching people how to think like doctors think. And that involves creating differential diagnoses. Okay? Identifying all the potential aspects of what that call could look like, why it's happening, and then cognitively thinking about why it is or isn't one of those things on the list. All right? The problem, of course, is when I was at Montgomery County, for instance, I was the medical director over 1,100 providers. Okay, we did 60,000 calls a year. It makes it very difficult for me to be right there with a paramedic in an 1,100 square mile county. So how can we as physicians and future physicians interact better with paramedics? All right. Well, we can train them better, but we can also utilize technology like this is a picture of some telemedicine interactions where the medics can call us and have a real life interaction with a physician when they're not sure what's going on. Okay? We can also do things like we do, like you'll do during residency, to create lifelong patterns of quality improvement within your system. That is identifying self-directed learning issues and finding out the answers to those things. Patient callbacks to find out how the patients did and what their final diagnosis was. Other quality improvement issues, M&M type of sessions, and then evaluating your system or you according to the benchmarks of the system. We also do things like journal clubs where we teach the paramedics to interpret the literature. All right. So paramedics traditionally will respond to a question. Well, I was taught that, or the way we did it when I learned this was this way. Instead of actually understanding the evidence and appreciating that the evidence is going to change. All right, I'm sure your first day of medical school was like mine, which is you're going to learn stuff this year, and we're going to teach you it's going to be absolute fact. And at the end of your 4 years, it's going to be completely wrong. Okay? We have to train paramedics to think the same way, and that involves physician-level support. All right? So the future really of EMS is degreed paramedics. It's taking folks who are interested in medicine, who like the excitement of emergency medicine, but don't want to go the medical school route. All right? It involves significant contributions from physicians to really help shape paramedic practice, to identify patterns of behavior within systems, to create change in the systems, and ultimately to provide better care in the pre-hospital environment to people. Questions? Sorry, that was fast. These are my email, Facebook, LinkedIn. I have Twitter now. I don't know how to, well, I have a Twitter account, but I don't really Twitter that much. There's somebody.
My question would be, how do you...
What's your name and where are you from?
Oh, I'm Blaine. I'm from Lubbock.
I'm so sorry.
I'm actually from Tulia, which is a much smaller town. And so Lubbock to me is huge. My question would be, my best friend is a paramedic. He's a flight medic in New Mexico. How would he then transition with his current credentials into that? How would you switch that? Because I know that's what he's going to ask me when I tell him about this.
Well, the problem is it's going to take an organized effort to decide that this is in fact where we need to go as a profession. All right, so there are a lot of political aspects to EMS. In fact, a significant portion of my job as a medical director is playing politics with other stakeholders. I'll leave it at that. It sounds nicer that way. But the fact is that when you talk about raising salaries from $40,000 to $100,000, you know, the stop signs pop up and people say, well, we can't afford that. Well, that's true. All right. And the big opponents, there are two groups that are big opponents. Number one is the mass of EMTs who know that they could never, I shouldn't say that. It would be very difficult for them to ascend to having a bachelor's degree and being a degree provider, a credentialed provider. And then you have the big cities that say, well, that may work in the small town you just mentioned, but you know, I've got 600 paramedics and there's no way I can afford to pay 600 paramedics that kind of money, which is not really true. Okay, so those of you who are familiar with EMS systems know that we've got a lot of systems that have 2 paramedics on an ambulance. All right, this would be akin to having, you know, a freestanding ER that has 2 doctors and no nurse. That's kind of dumb, right? On an ambulance, you need a technician that does the usual roles. They wash the ambulance, they stock the truck, they clean the toilets at the station, whatever it is. That's the entry-level position. And you need a clinician who, when they're not taking care of patients, they're reviewing calls, they're reviewing literature, they're becoming a better clinician. All right, this is what the problem in EMS is, that we haven't distinguished between those 2 roles, and there really should be a distinguishing transition between the 2, so that we can afford to pay one a bunch and one not so much. Yes, sir.
All right, last question here. I love the idea of transitioning, having more education, everything for the paramedics. But coming from an EMS background, one of our biggest problems with staffing in general, we never had enough employers. So we were pushing, 100 hours a week, just to cover the shifts or the necessities on that. So how would we kind of tackle that issue with requiring more, or having more requirements, credentials for these positions, while maintaining the 24/7 staffing problems that a lot of EMS agencies?
Yep, I'm glad you asked that. I've got a couple responses. The first response is, Australia had the same problem. Okay? And the reason, I think, is because when you're offering $40,000 as the top end of pay, it's not very attractive. Now, in Australia, they have a test called the GAMSAT, which is similar to the SATs or ACTs, which basically, how you score depends on what you can do. All right, number 1 is law, number 2 is medicine, number 3 is ambulance studies. All right, it's the 3rd most popular thing to do out of high school now because of the salary change. All right, it's going to take an investment in time. It's going to take people sacrificing, saying, you know what, the long-term goal is we have to make this transition, and if we do it, we're going to get more people in the industry, and they're going to stay in the industry. Because what happens right now is people who are smart and talented become you people. All right, they go to medical school, they go to PA school, they go to nursing school, right? Because nobody wants to stay making $40,000, working 100 hours a week, getting shot at, stabbed at, peed on, and these sorts of things. It's a challenge, okay? The other answer I have for you is we have to stop thinking that every community needs to have a paramedic, okay? If we don't have the call volume or the resources to do it, then we have to take a step back and say, it may be better to have lower level trained people who are capable of maintaining a lesser standard of care in communities that cannot support having paramedics there all the time. Because you can't have people working 100 hours a week, because like we found out in medicine, it turns out you kill people. All right, so you guys have a cap of 60 hours a week now, is that right? For internship, residency? Yeah. All right. Yeah, there's no limit in EMS, which is kind of dumb.
All right, well, thank you. That's all the time I have.